Hi everyone, good evening. My name is Adi. I am the Geriatrics lead at Mind the Bleep and also the webinar lead. Thank you for joining our last session in this series, the Geriatrics Crash Course. And today we'll be talking about a topic that is very frequently encountered in a variety of inpatient settings. Specifically, we're going to be going over the topic of dementia and cognitive disorders. So just a brief series overview. So as I mentioned, this is unfortunately the last talk in the series. However, we've got all these other webinars are available on our on-demand page on YouTube. If you go to the Mind the Bleep page and then navigate across to the live tab, you should be able to see all these recordings. Hopefully some of that is useful. There's a lot of interesting topics and conversations in there from some guest speakers as well. So I think it's worth going through some of that if you have an interest in geriatrics. But so focusing on today's talk, we're going to be going over the common types of dementia and how they differ. We're going to be talking about cognitive disorders that mimic dementia in both the acute and the chronic settings. I want to help you develop a structured approach to assessment and diagnosis, and how to outline the principles of medical as well as non-medical management, which does make a large part of what we're doing. I also will briefly touch on the pharmacology and prescribing of common dementia medications, including some of the common pitfalls that people encounter when they're trying to prescribe these for the first time. And I think it's always important in anything that affects someone's cognitive status to think about the legal and capacity aspects of cognitive disorders. So I'm going to briefly be touching on that as well. So firstly, what is dementia? Well, feel free to pop any thoughts that you have about kind of how you define it in the chat. But as for the NICE guidelines, it's a clinical syndrome that's characterized by a progressive and usually irreversible decline in multiple areas of cognitive function. So there's several different domains of cognitive function which are assessed, and these are deemed severe enough to interfere with their daily functioning. So in practice, you need at least 2 cognitive domains to be affected in order to be classified as potentially having dementia. It's not the same as mild cognitive impairment or delirium. Both these can mimic dementia, but they are distinctly separate conditions from dementia itself. There's a lot of subtypes. I think the most common subtypes in terms of distinct clinical entities that you'll see are Alzheimer's disease, vascular dementia, and Lewy body dementia. But it's also often fairly common to see a mixed picture with vascular dementia and another subtype of dementia, or kind of overlap pictures. So kind of mixed dementia is something that we very often do see. But let's start with the most common type. So Alzheimer's disease is far and away the most common type of dementia. It's also the most kind of well-known in and amongst the general population. So it accounts for around 60 to 80% of the total cases of dementia. And there's an equal male and female preponderance, and the typical age of onset is around 70, kind of going upwards from that age. In terms of how it happens, well, the key pathophysiological manifestation of it is that there is an accumulation of beta amyloid plaques and neurofibrillary tangles in the brain. What this does, and it typically happens in the parietal and the temporal lobes, is it causes neuronal death in the affected neurons, as well as some atrophy. And it then leads to kind of a generalized state of globalized atrophy across the hippocampus and the cortex, which is why we get the clinical manifestations that we do. It's often a very slow and insidious onset, so often people are able to mask it for a very long time before it becomes what we would typically classify as pathological. But the early features that we often see would be episodic memory loss, particularly for short-term memory more than long-term memory, disorientation, and dysphasias or word-finding difficulties. These can often be quite subtle, and oftentimes, if you don't know the patient, you won't really be able to pick up on it. It's often their relatives who are the ones who are able to kind of pick up on it first and flag it up. In terms of risk factors, there are a few genes that have been implicated in an increased risk of development of Alzheimer's disease. And that's particularly, and this is something you'll see in exams kind of throughout medical school as well as beyond, the apolipoprotein E gene is strongly associated with Alzheimer's. Specifically, it's the E4 allele. There's also an E2 allele, which interestingly seems to have a protective effect against Alzheimer's disease. There are also other genes. It's polygenic in nature, and obviously there's environmental factors that can also exacerbate the risk of development. EOFAD is another gene that is often implicated. But as I mentioned, there's a lot of non-genetic factors as well. So age, simply sort of just the aging process of the human body does increase the risk of developing Alzheimer's, and the incidence rate doubles about every 5 years after the age of 65. There's an inverse relationship between the level of education that someone has attained and the risk that they have of developing Alzheimer's. Head injuries, any sort of trauma to the head, increases the risk of beta amyloid production, and so this is also associated with an increased risk. And vascular risk factors, I appreciate there's also vascular dementia as a distinct entity, but they do also increase the risk of the development of Alzheimer's disease. So things like hypertension and diabetes, it's important to optimize as early as possible. Good diet, physical activity, and sleep are all protective factors as well, which is something that medical students and doctors are not very good at, so please look after yourselves. In terms of the clinical features, so we discussed the cognitive changes briefly earlier. So it's often kind of early onset, recent kind of short-term memory loss. But we also get executive dysfunction, which can again be quite subtle. So things like difficulty making decisions, performing complex tasks, and some of the assessments that we use to try and assess for Alzheimer's disease try and capture some of this. Another thing that's often seen in Alzheimer's disease is what's colloquially referred to as BPSD. So BPSD stands for behavioral and psychological symptoms of dementia. So common things that you'll see in patients who are developing dementia include low mood and agitation, a degree of apathy, also sometimes a degree of disinhibition. So they're not acting like themselves, and they're a lot more kind of forward than they normally would be. Coming on to how we actually diagnose the condition. Well, I mentioned some of these earlier briefly, but the cognitive tests do form an important aspect of how we diagnose dementia, and this is often what will be done either in the inpatient setting or in the outpatient setting in memory clinic. The MOCA, which I have a screenshot of on the right over here, is an example, and that's probably the best known example of a cognitive assessment. This is scored out of 30, and there's a number of domains of this test. So I don't know if you can see, it might be a bit small on your screen, but the kind of shapes and numbers in the circles in the top left essentially assess your visuospatial executive function. And just next to it, there's a blank space whereby the patient is asked to draw a clock showing the time of 10 past 11. Then naming various animals, some memory tests, and so on. So there's a number of aspects, and basically what this does is it gives quite a good overview of someone's current cognitive status. And it gives us a score which we can use to stratify people into kind of how severe their cognitive impairment may be. So a score of less than 26 is suggestive of cognitive impairment. This is primed towards executive dysfunction. Just important to kind of mention that as well. There are a few other tests that we can also do. So the MMSE, which is also out of 30. And in this, a score of less than 24 is highly suggestive of dementia. But this one's a little bit limited, especially if you're living in an area which is quite heterogeneous in terms of its population, such as London, because there's a number of confounding factors. So language, cultural background, and education all reduce the utility of this test. And so it's often used less than some of the other ones that we have. There's also a much longer test that's often used in the memory clinic setting. So it's called the ACE-3. It stands for Addenbrooke Cognitive Examination 3, and it's scored out of 100. As I mentioned, it's generally only done in memory clinic because it's a much more detailed cognitive profile, but it is useful if you're really trying to cinch the diagnosis. Aside from those questionnaire-based tests, it's important to exclude other causes of cognitive change. So there's a lot of things that can mimic Alzheimer's disease or more broadly dementia. So whenever anyone's coming in with confusion, just in general, it's important to send off what's known as a confusion screen. So a B12 and a folate level is important to send off. These can cause cognitive changes. Thyroid function tests are also worth doing because these, someone's profoundly hypothyroid or indeed hypothyroid, this can manifest in a cognitive fashion as well. Electrolyte abnormalities can sometimes also mimic some of these conditions. And if someone's got severe CKD, which is untreated, or a really bad AKI with significant uremia, uremia itself can also cause significant levels of confusion or uremic encephalopathy. It's important to assess for that as well. Liver dysfunction, so hepatic encephalopathy in the context of liver disease, something like alcohol-related liver disease, it's important to look for evidence of this as well because that can also cause confusion. Other mimics, delirium, even if you've excluded all these other factors above, is often common, particularly in the inpatient setting. So anyone who's perhaps more prone to delirium, when you toss them into A&E, where they have to wait in A&E for several hours on an uncomfortable stretcher, with the lights on kind of throughout the night, it's not really a conducive environment for them to stay oriented. So it's not unusual for someone's delirium to get worse in the hospital setting. And so that's the main reason why we can suggest that there is a diagnosis of dementia to someone or to their relatives, but we rarely actually diagnose dementia in the inpatient setting. We normally flag this up as something that should be diagnosed and investigated further in the outpatient setting in a specialist memory clinic, because the person will be back in their home environment, they'll be kind of more comfortable, whatever the acute illness is that brought them into the hospital will have hopefully resolved. So a lot of the confounding factors that might also cause confusion will have been removed to allow us to make a more accurate assessment of their cognitive state. Imaging is useful. It's not always diagnostic, but there's some useful stuff that we can glean from intracranial imaging. So CT head, for anyone who's confused, is something that most A&Es will hopefully just get done at the front door. It's a very useful screening test because it can often pick up really big barn door abnormalities. There are changes on a CT head, including a plain CT head, that are suggestive of Alzheimer's. It's a generalized atrophy, pronounced sulci and gyri, and kind of involutional changes, microvascular changes are commonly seen on a CT head, and the radiology reports will often pick up on this as well. And yeah, it's useful to rule out other causes of confusion. So something like a subdural hematoma often presents similarly in a very kind of subacute fashion, but it's important to exclude this as a cause as to why someone's confused, because the management is obviously very different. An MRI brain is a much more obviously high resolution scan that can be used to assess for hippocampal atrophy in particular, which is obviously strongly implicated in memory. So that's quite useful. And sometimes we can use in tertiary centers normally amyloid PET imaging. So this can detect amyloid plaques, but it's an extremely expensive test and it's not always available. And the actual amount of utility that it has in terms of adding on to a kind of diagnostic workup is limited. Sometimes if there's diagnostic uncertainty, we can actually do a lumbar puncture on these patients as well. So CSF analysis often shows a reduced level of something called beta amyloid 42, as well as an increased level of tau protein, which we obviously know is one of the things that increases in Alzheimer's disease. But yeah, we only generally use that if there's diagnostic uncertainty. Sometimes if someone's coming with an infection, confusion, we may sometimes consider a lumbar puncture if there's other features that suggest meningism or encephalitis, although not always. But we can also sometimes use it diagnostically in the context of Alzheimer's disease. So management, we addressed earlier some of the modifiable risk factors. Blood pressure control, glycemic control, stopping smoking. One of the big risk factors for development of confusion, delirium, etc., is actually social isolation. So elderly people who live on their own, who don't necessarily have a network around them to look after them, will often have an accelerated pathway of development into something like Alzheimer's disease. So it's fallen a little bit out of fashion recently, at least from what I've seen, but social prescribing, whereby you kind of medically give someone a group for them to go and hang out with and socialize with, is something that's quite useful, community groups, because it just provides intellectual stimulation to the at-risk populations. Emphasizing a good diet, so diets that are rich in saturated fats and simple carbs, is often quite useful, and engaging in regular exercise, because that tests a lot of those kind of more executive function aspects that deteriorate in dementia. There's a couple of other conservative kind of non-pharmacological things that I wanted to highlight. So cognitive stimulation therapy is something that's often prescribed. So it's kind of structured 1-hour sessions, often weekly, that are focused on discussions or cognitive engagement. It's normally done in a group setting. So it's similar to kind of a group CBT class, but it's specifically focused at this group. And I think simultaneously, as with some of in a lot of the other webinars that we've done, it's useful to get occupational therapy or social services involved early, just to make sure that the patient's home environment remains safe. Because with cognitive changes, we obviously don't want them to then have an increased risk of falls and then have a fall and a neck or femur fracture, which carries quite a high mortality rate. We're coming now on to pharmacological management. So the medication that is most often prescribed, which is often first line, is a class of medication called acetylcholinesterase inhibitors. And the ones that you'll often see are donepezil, galantamine, and rivastigmine. What these do is they inhibit an enzyme in the CNS, which is called acetylcholinesterase. And as the name suggests, this breaks down acetylcholine. So by inhibiting the enzyme function, this increases the level of residual acetylcholine that remains at the synaptic receptors. This then increases kind of the rate of neurotransmission and reduces the symptoms often. This is, as I said, first line and is used or advised to manage mild and moderate Alzheimer's in particular. And most often we see donepezil being used, but this is relatively contraindicated in bradycardia. The starting dose for this would be 5 milligrams at night. The second class of medication that we'll often see, which is normally only given after someone has tried one of the cholinesterase inhibitors, or if they were unable to tolerate it, or if they've got severe Alzheimer's, is the NMDA receptor antagonists. And the main one for this is memantine. The dose for this, helpfully as well, is 5 milligrams, but it's once a day. What this does is it blocks glutamic activation of NMDA receptors. And this is thought to be protective against the loss of neurons, and it improves kind of cortical processing. So it's quite useful. Normally, this is only, as I mentioned, used in moderate or severe Alzheimer's. It can either be as an adjunctive therapy to, let's say, donepezil, or it can be as monotherapy. And we normally start people on the lowest possible dose that we can, and then up titrate it if it's well tolerated. And there's a number of side effects that these medications obviously carry, which are important to be aware of as well. So that's why we start it slowly and kind of work our way up. So that is the kind of gist of Alzheimer's disease, which is obviously the most common form of dementia. Please, again, as I mentioned, do pop any questions into the chat as we go along if anyone has any questions about any aspects of what I just talked about. But otherwise, I'm going to go on and talk about the second most common type of Alzheimer's, which is vascular dementia. And so what this is it's a group of syndromes that essentially all arise as a result of cerebrovascular disease. So chronic ischemia or hemorrhage will lead to changes in the brain, which result in something that looks like dementia. There's a few different subtypes. These are just some of the subtypes. Subcortical vascular dementia is caused by chronic small vessel disease. So you won't see a big stroke on the CT scan, but you'll see lots of kind of small plaques, calcifications. Patients will often be hypertensive and kind of have issues elsewhere as well. You then see stroke-related vascular dementia. So these are kind of caused by discrete infarcts. This can either be a single infarct vascular dementia or a multi-infarct vascular dementia. And you'll be able to see these on the CT scan. And we often see kind of a mixed phenotype. So the patient will have features of both vascular and Alzheimer's disease. So risk factors, obviously, as the name suggests, would be largely kind of vascular-related things. So strokes and TIAs are obviously the biggest risk factor. Atrial fibrillation increases your embolic risk. That's one of the reasons why we talk about anticoagulation when someone's found to have AF. Poorly controlled hypertension also increases the risk. High cholesterol, smoking, obesity, and diabetes, and a previous family history of either strokes or just generally dementia all increase the risk of vascular dementia. So the key distinguishing clinical features, the way that we tell vascular dementia apart from Alzheimer's disease, for example, is kind of, you can see if you kind of get a good collateral history from the patient's relatives, you'll see a history of kind of a stepwise decline. It's often preceded by a stroke, but it can be a bit more kind of subtle than that. But you'll see kind of distinct points at which someone's cognitive function was found to be declining. There's often kind of changes in personality and mood also associated with this. And obviously, because it's a vascular pathology, we often see signs of strokes in other parts of the body. It does progress at a variable speed. So if someone's having kind of lots of crescendo strokes, then it's more likely to progress much quicker than someone who's had one stroke and then is just kind of continually at risk. So in terms of diagnosing vascular dementia, it's slightly different to how we do Alzheimer's disease. So diagnosis for this, cognitive tests are useful, but they're not diagnostic in the same way that they are for Alzheimer's disease. Blood tests, again, as we discussed earlier, sending off your confusion screen, making sure they're not profoundly hypothyroid, encephalopathic, and so on. It's always useful to do because those things are managed very, very differently. Imaging is understandably a key aspect of diagnosis in these patients because you're looking for evidence on a CT scan of infarctions, you're looking for evidence of white matter disease, or just generalized age-related involutional changes. Given that the pathology is vascular, we want to do an ECG or a 24-hour tape. We want to get an echocardiogram to look for evidence of AF, because AF increases the risk of embolic ischemic infarcts. And if someone's deemed high risk for stroke or has had a few strokes, we often, as part of a stroke workup, will also get carotid artery Dopplers, because there's often big thrombi sitting in the carotid arteries, which are increasing the risk of embolization into the brain, which will cause further deterioration in cognitive function. So this is really important to know, if someone's been diagnosed with vascular dementia as opposed to Alzheimer's disease, there's no specific management, kind of pharmacologically speaking, for vascular dementia, unless there is an overlap with the other subtypes of dementia. So instead, a lot of the focus is on optimizing the quality of life for the patient and making adaptations for the individual. So that's where your occupational therapist and so on will get involved. Cognitive stimulation programs, as I outlined earlier, are quite useful. But always, as with most aspects of medicine, prevention really is key. There was just a comment in the YouTube chat, which I'll just come back to in just a second, but thanks for the question. Optimizing risk factors like hypertension, hypercholesterolemia, and so on is really important. But once someone's diagnosed, you think that potentially, giving someone aspirin or statins in terms of secondary prevention is useful. There's actually no strong evidence to say that aspirin or statins slow the progress or treat vascular dementia effectively. So moving on to the third subtype, I'll just quickly look at the question that we had in the chat. So did some research on Alzheimer's a while back and read that there was some contention about which pathophysiological theory was the main accepted. Beta amyloid or tau. They generally both know those. So I've seen a lot of the same kind of contention in the literature. I think there's evidence for both. Particularly as I mentioned, we often use diagnostic lumbar punctures, which show kind of elevated levels of tau. However, amyloid can be picked up on a nuclear med scan. I think there's some evidence for both, but I don't think we have a single kind of unifying disease agent that we found. But that's definitely something I'm going to kind of go back after this webinar and have another read of, because I think there's a lot of contention in the literature. But thanks for flagging that up. Often with these things, it is slightly unclear as to exactly what's causing the pathology, and often it's kind of only post-mortem analysis of brain tissue that helps us see what is or isn't there, because obviously we don't biopsy people to diagnose Alzheimer's disease. But I think it's something that's still very much evolving. Thanks for the interesting question. So moving on to dementia with Lewy bodies. So this is the third most common type of dementia, and accounts for around 5 to 10% of cases, often because it wasn't actually really recognized, let's say a couple of decades ago, as a big cause of dementia because of the overlap with Parkinsonism, which is what I'm going to highlight in a second. So the key diagnostic feature is accumulation of alpha-synuclein misfolded proteins. So these are colloquially known as Lewy bodies, and this happens in the cortex and in the brainstem. These are intracellular inclusions that misfolded proteins, and these proteins normally contribute to healthy synaptic function. So if they're misfolded, then there's a kind of resultant deterioration in how the synapses are functioning. In Lewy body dementia, it forms insoluble fibrils within the neurons, and this causes the Lewy bodies to form. And what this does is it results in indirect damage to mitochondria within the neurons. It also inhibits the degradation of other toxic metabolites, so those can also build up and cause further damage. And there's reduced transmission at the synapse of vesicles and neurotransmitters. So there's kind of there's kind of multifactorial means in which the Lewy bodies contribute to a deterioration. So where the proteins kind of distribute in the brain does affect how the disease manifests. So if they accumulate particularly in the substantia nigra pars compacta, which is a thing that you might have heard of if you've ever done any reading up about Parkinson's disease, this results in the loss of dopaminergic neurons and results in Parkinsonism being the kind of hallmark feature. And of course, the triad, as we know for Parkinson's disease, is rigidity, bradykinesia, and tremors. If it accumulates in the occipital cortex, unsurprisingly, it causes visual hallucinations as the main symptom. And if it accumulates in the frontal or temporal regions, it can cause cognitive impairment, behavioral changes in executive function. So there's a few different ways in which this often manifests. And in terms of how it does manifest, so we see progressive cognitive impairment, and unlike Alzheimer's disease, there's early loss of executive function, so people aren't able to mask it as well. But the big thing really is that there will normally be features of Parkinsonism. Normally, this comes on after the cognitive impairment. So we can typically say that it's either dementia with Lewy bodies if the dementia or the cognitive changes come first, or otherwise we'll say it's kind of Parkinson's with cognitive impairment if the Parkinsonism has come on first. And this is particularly, again, if the Lewy bodies accumulate in the substantia nigra pars compacta, because that causes loss of dopaminergic neurons, and that results in the motor changes. As I mentioned, if the occipital cortex is involved, we will see visual hallucinations, and something that's often kind of a sentinel feature of both dementia with Lewy bodies as well as Parkinsonism is REM sleep behavior disorders. So people kind of acting out of their dreams is something that will often be described. Normally, at least from what I've seen, it's a retrospective thing that they realize that, for years they've been kind of acting out of their dreams, but that's something that's been quite strongly associated with the development of Parkinsonism or dementia with Lewy bodies. So in terms of how it's investigated, so it's typically a clinical diagnosis because it has a lot of these hallmark features. A DAT scan is useful. What this does is it measures the uptake of dopaminergic iodine, which is a radio-labeled medium or tracer in the basal ganglia. So in dementia with Lewy bodies, there's a reduced uptake of dopaminergic iodine, and that can be quite diagnostic. But it's a tricky scan to get. So we often will kind of diagnose someone and then just get this as a confirmatory test a little bit later on. So how do we manage dementia with Lewy bodies? Well, there's really good evidence to support the use of acetylcholinesterase inhibitors, just as it was for Alzheimer's disease. And rivastigmine in particular has been kind of strongly found to be beneficial. Something really important, and this is something that hopefully lots of people have told you in the hospital setting, or they will going forwards, is as far as possible avoid antipsychotic medications, because these essentially oppose the kind of intended benefit of Parkinson's meds. They will kind of reverse any intended benefits, and they'll exacerbate the Parkinsonian symptoms quite strongly. You manage the motor symptoms just as you would with Parkinson's, so dopamine agonists, etc. But just be aware that this will often worsen the psychosis element of the condition, which is why for kind of schizophrenia and so on, we'll use antipsychotics because they're dopamine antagonists often. So it's a tricky balance to strike, but you just need to be careful when you're prescribing any antipsychotics. So just quickly, just heading towards the kind of last few slides of the talk. But again, I'd be very grateful for any questions in the chat. But something that I think is always really important to think about is differentiating between dementia and delirium in the acute setting. They are distinct clinical conditions. There is a degree of overlap in terms of the symptoms that they have, but by and large, in the acute setting, they often will mimic each other. If someone's not known to have dementia and they're usually cognitively intact, but they've now presented with acute confusion, this is typically more consistent with the delirium than a dementia. And so a collateral history is really useful if someone is coming acutely confused. So their carers, their next of kin, whoever it is, it's useful to have a chat with them because this will enable us to understand what their baseline is and as to whether what we're seeing now is distinct from that or as to whether this is kind of just their baseline. Patients will have often been struggling with, as I mentioned earlier, some aspects of memory for a very long time. They can often mask it quite well, but then they get tipped over in the acute setting, whether in an unfamiliar environment with lots of other things and noises and so on going on around them. They'll get tipped into a kind of acute confusional state, and that will often present in the sense of delirium. Just again, harp home the same point. Infection, new environments, nutritional deficiencies, sleep-wake cycles, changes to medications or new medications will all often precipitate a delirious state. And so we can't really diagnose dementia in the hospital as a result of this because there's so many confounding factors, and diagnosing someone with dementia is really a life-changing diagnosis, and it's important to do this properly. So if we're not sure that we can diagnose it kind of with a good degree of certainty, we generally avoid doing it in the inpatient setting. So you'll often see, depending on where you're working, on discharge summaries, people writing GP to kindly kind of facilitate a memory clinic referral because that's a much more stable setting for someone to have this assessed in. Yeah, it's just saying the same thing again there. And so this is just coming towards the end now of the talk, but I just wanted to touch on aspects of kind of medical legal capacity issues as they relate to dementia. So, unsurprisingly, with these cognitive changes that occur for people with dementia, they will often be thinking about kind of what the implications are for them and their families going forward. They'll have, they'll have housing, they'll have finances and so on that they want to kind of make sure are well looked after. And so it's often suggested to people who live with dementia that they organize a lasting power of attorney. So what this is it's a nominated person who's often a family member, but can be a close friend or someone else that the patient chooses to nominate with capacity. Basically, it needs to be someone who they trust will advocate for them and will make decisions on their behalf that they will broadly agree with. Now, in the UK, the main two types of LPA are for health and welfare, and separately, there's one for finances and property. So if you're clerking someone in or you're reviewing someone and someone has said that they have a lasting power of attorney, just clarify with the person as to which LPA it is. It's often both, but we do need to check because it's not always the case. And something that's really important to just kind of emphasize is that lasting power of attorneys are only active when someone is actively lacking capacity. So capacity isn't something that someone just loses. It can fluctuate and it relates to a specific decision at that moment in time. So let's say someone has a known diagnosis of dementia, but they've come in with pneumonia and they've very clearly said that they just want to go home. They don't want to be in the hospital. They kind of don't want to come back into the hospital. If they've said that and they've been deemed by kind of the various members of the medical team to say this with capacity, then I think we need to be really careful in terms of kind of listening to their wishes and making sure that we're able to do what they're expressing is right for them. And this would be kind of irrespective if someone has an LPA if they've been deemed to have capacity. So capacity always supersedes lasting power of attorney. It's only a document that's put in place when someone doesn't have capacity. That's just important to know. So just coming towards the end now with a summary and conclusion slide. So dementia is an increasingly common condition across the spectrum of older patients in the UK, and it's something that we're going to see more of as time goes on because we're getting much better at treating other conditions and therefore life expectancy is increasing. So we do see a lot of these chronic changes a lot more. Alzheimer's is the most common subtype, accounting for, as I mentioned, around 60 to 80% of total cases. The other common kinds are vascular dementia, dementia with Lewy bodies, but there's also a number of other subtypes, and there's obviously mixed pictures as well. It's important when someone's coming confused to make sure that this doesn't just represent delirium. And there's a number of diagnostic tests that we use if we think that this is truly dementia. So cognitive testing with things like the MOCA, the ACE3, and the MMSE. Imaging, so CT scans, MR, nuclear medical scans, plus minus a lumbar puncture can be used in order to formalize a diagnosis. Some types of dementia do respond to medications, but not all of them. So it's important to know which type of dementia someone has and also what the common medications are, how they're prescribed and up-titrated, and kind of how we manage them. And if someone has dementia, it's always better to be proactive in starting the discussions around lasting power of attorney and discussing these things and encouraging the patients to discuss these things proactively with their loved ones in order to plan for their future. So that brings me to the end of the webinar. Sorry if it was a little bit on the shorter side, but hopefully it was useful. If you scan the QR code on the screen just now, it'll take you to our website where you can complete a feedback form, which will also generate a certificate which you can use for your portfolio. If anyone has any questions at all, please do pop them in the chat. I'm happy to answer anything if anyone has any burning questions. But otherwise, thank you very much for attending the webinar, and it will be available, as with all of our other webinars, on YouTube shortly after we end the stream. So I'll leave the chat open for a few minutes, and I'll just let you guys get the QR code, and then I'll shut the webinar down in a couple of minutes. You're welcome.